Welcome to Healthcare in Hawaii. I'm your host, Josh Green, State Senator and ER Physician on the Big Island of Hawaii. Today I'm really excited to have a new guest from HMSA, who's one of their medical directors, John Baleix. He's been with us here at HMSA for 2 years, but spent 29 years in the Navy serving as its Director of Public Health. So John has a very broad perspective on healthcare needs, both in the military, in large communities, and now for our state. Over the last several months, we've been having a very significant dialogue about the healthcare system in our state. We started with Beth Giesting, the healthcare czar for Governor Abercrombie, and she laid the foundation about what we're doing for the healthcare transformation in our state, particularly at policy level. And we've proceeded to have conversations about access, about what the John A. Burns School of Medicine is doing with Dean Hedges. Last week we had a professor who spoke with us about healthcare disparities and the impact of both poverty and injustice in our healthcare system. Kiave was able to show us that people who are Native Hawaiian have much worse outcomes in healthcare in our state and have difficult time getting care. We've had so many conversations that really we're digging deeper into the healthcare system each week. And today I'm hopeful that John will be able to bring us back to that 30,000 foot level where we talk about the overall perspective of healthcare transformation here in our state, particularly with patient-centered medical home and other projects he's interested in. So I want to introduce John. He's a medical director at HMSA, and I really want to just have an open conversation about how can HMSA and the things that you're working on help us get better care for our patients.
Great.
So tell us, John, a little bit about yourself. Where did you get your training? What's your area of interest?
So I'm a California boy, did my undergrad in San Luis Obispo, studied biochemistry thinking I wanted to work for the EPA or something, and middle child rebelled and ended up going to med school at Baylor in Houston. Mm-hmm. To do that, though, it's a private school, so I needed a way to fund it. I got a Navy scholarship, and surprisingly had a very good, very fulfilling time in the Navy.
29 years later.
29 years working with teams and having something to live by.
What's it like being a doc in the Navy?
I'll just tell you, my first day of clinical work in the Navy kind of typifies. So I did a medicine internship at a Catholic hospital, and my first assignment is 1st Marine Division, Camp Pendleton. I arrive at the clinic, people all over the place. The senior chief greets me, "Oh, you're the new doc. Great to see you. You're the only doc today." I said, "Yeah, it looks pretty busy. How many patients we got?" 56. "What kind of problems?" "Oh, mostly orthopedic, knees, backs, ankles." I did 2 weeks of ortho in med school. So I learned very quickly. I said, "So I got any help?" "Yeah, we got 6 corpsmen working today. I'll send them to your office." And so I learned from day one the value of team care, of working with my colleagues, whether they're docs, nurses, or support staff like hospital corpsmen, how together we can provide the best care for the patients. And so I'm a middle child, maybe that's why I like the team thing. Ironic that a San Francisco kid ended up growing up during the Vietnam War in San Francisco, ended up serving in the Navy. It took me a while to work it out in my conscience that it was good to do, but when I thought about if somebody's attacking my friends and family, I would not be a pacifist. I would resist and stand up for what I believed in. So that's what hooked me, and so for 29 years, that's what I did. I discovered Hawaii my first year in college, came over with a buddy in '75 and was angling to get back ever since. In 2000, the Navy finally had opportunity for me to work at Pearl Harbor directing public health. And so I was really eager to stay here, and so that's what led me to retire. And I'm really thrilled to be working with the community to try to make healthcare better.
It's interesting. It's been an interesting process. And you mentioned that teamwork was a kind of a central focus of your early clinical experiences, and that seems to be translating now into what you're doing at HMSA. Why don't you tell us about the teamwork concept of healthcare and how that's beginning to kind of ripple through our system?
Well, one of the fundamental challenges in healthcare in America, and healthcare everywhere for that matter, is that it's expensive and it's complicated. And it's tough to do everything efficiently. Right. And what we have in the United States is largely a result of some of those challenges that have both grown and festered as a result of sort of a laissez-faire free enterprise system. We have great things that private enterprise has innovated and that leads the world, frankly. Right. But at the same time, we have a fragmented system, and a system that began with good intentions to cover those expensive surprises in life when, somebody gets very sick and they don't have the means to take care of them, so that's how insurance came about.
Right.
But it has fueled over decades an episodic system that really in primary care has become sort of like streaming urgent care,
Right.
more than a continuous therapeutic relationship that takes care of the whole person. I mean, we've heard for years that probably the majority of primary care visits come with some emotional component to it. How often has that been really addressed
Right.
in the standard practice that we've all grown up with? And how does that leave the human beings that we're taking care of?
Right.
How does, and then, so that's sort of the care aspect. The cost aspect, in the U.S. we're spending at least 1.5 times what our industrial allies around the world are spending. Well, it's government and employers that are funding that by and large, so
Right.
that makes our products cost even more, which makes a lot of our businesses want to set up factories overseas.
Right.
We know in Hawaii all too well, our kids go to college and then they want to come home, and it's hard to find good jobs here. So health and finance are all connected, and that if we want to solve the economic woes of our nation, we need to start with healthcare so that we can keep our people healthier and do so in a way that's sustainable so that our businesses can prosper and our people can prosper.
So you're saying a couple things there. It sounds like, number one, healthcare is very expensive in our country. People can't afford it. And we need to change our system somewhat to make it affordable. And that's what, I guess, the root of the Affordable Care Act, from your perspective, was about?
It's certainly one of the aims. I think their Institute of Medicine has done pioneering work to set the course for our nation, and cost was certainly one of those, but access is certainly another. People that don't have access to routine care aren't able to address things early in the course of the disease, and
Right.
so they wait until they can do nothing else, and they come in, very well, working in ERs.
Right.
People who don't have access to routine care come in, and they're in a very advanced
Yeah.
and thereby expensive state of the condition, and their livelihood, their family life, and their longevity suffers
Right.
as a result of not having access. So I think access is the other fundamental piece of the affordable care.
So we've touched on that. So in order to get affordable care, we have to give better access. And we've talked about this here on the program a little bit before. We have about a 22% shortage of healthcare providers, or at least a physician shortage of about 22%. But that doesn't necessarily mean we don't have other ways to solve the problem rather than just pile on a bunch of docs, right? So we first have to look at what you said, like cost and the episodic nature of care, but also this access question. You aim to solve this in some creative ways, is my understanding.
Well, we're part of a national movement to focus on primary care. And I talked about, for a number of reasons, but probably principally among them is our fee-for-service
Right.
payment system has led to streaming urgent care. What's your problem today?
Right.
And address that. And you say, oh, but doc, I got these other questions. Oh, I'm sorry, I don't have time. You'll have to make another appointment.
Right.
So a fundamental piece of patient-centered medical home, which is really the revolution of primary care, is to take care of the whole person. And that means not only addressing the problem of the day, but taking stock of who you are and where you are in your life trajectory and what are the things that are likely to trip you up at this stage of the game. Preventive screening for cancer and whatnot, screening for blood pressure, heart disease, diabetes, and along the way counsel you on healthy lifestyles. Another important piece, of course, most people who have had any significant health in their family realize is the difficulty of transitioning from a hospital or emergency department back to their primary care physician. So we want that to be part of the primary care safety net also. These are lots of things to do. We can't pile more on docs. They're already very busy. We want the docs to be using their brain and their soul to connect with the patients. They need help, and that's where the team comes in. And so we want to make it easy for the team to succeed, give them guidelines that they can work by, educate them, so that they can be proud of what they do and contribute in meaningful ways to augment what the physician community can do. There are allied professionals as well, advanced practice RNs and physician assistants that can further complement.
I was going to ask you to unpack that a little bit. So you referred to the team, so to speak, the healthcare team. Why don't you give us an illustration of what a healthcare team will look like going forward in your mind as a medical director at HMSA. What is a healthcare team? What will that mean to my patients on the Big Island or a family out there that's watching our program? Because historically you saw the doc going way back, maybe you saw the nurse. What is a healthcare team for tomorrow? What's a patient-centered medical?
Maybe a good way to illustrate that is with a couple of the innovative pilots that we've seen practices engage in here in Hawaii. So a couple practices have established a regular, recurring, predictable presence of somebody called a diabetes educator in their practice. Diabetes is a very complicated condition for medical professionals, even more so for somebody that doesn't have the benefit of the education that we have.
Right.
And historically, the doctor has told the patient what they need to do. The patient doesn't do it, but they're just not compliant.
Right.
Well, come on, that's unreasonable, and we need to help people better do that. So a couple of these practices have put a diabetes educator who's a dietitian or a nurse, a pharmacist, they can be of various backgrounds, with expertise in communicating and helping people understand. They put them in the practice so and then they schedule their diabetics on that time when the diabetes educator will be there. Doctor sees them, and they walk them down the hall and say, I'd like you to work with Mildred, whoever.
Right.
And they have seen profound improvements in the control of diabetes, reduction of emergency room visits, to the extent that they really want to make this standard of care. And the American Diabetes Association, for instance, reports that most diabetics sort of have a seesaw course. They get tuned up often with diabetes education, and then after about 6 months their practices start to wane and entropy sets in, whatever. And so that's what they recommend. It's good for diabetics to get education every 6 months so that we can learn how we can best help them. And a fundamental piece of the education is to really do the Stephen Covey approach to patient education, which is the antithesis of the paternalistic model that we were trained in, where we tell them what to do, is to seek first how they understand things, where they're at, what are their challenges, and then help them, starting from where they're at, to work forward to better control their conditions.
And so by doing this, your traditional visit to the physician is now a visit to the physician team, which includes this diabetes educator,
for instance,
who's got more time, they're empathetic, and we pay for that diabetes educator by not having those costs in the ER, or by not having complications where people need surgery or other issues.
And the other thing, we got to remember who's paying for this, the employer. So a diabetic who's under better control is going to be on the job site much more. In other words, away from the job site much less. And when they're on the job, they're going to be with it and able to function to the top of their game.
And it's so common now, diabetes. I think it's not lost on me. Before we take our first break, I think it's good to remind people that in the United States, these numbers are crazy numbers, but we spent $3 trillion on healthcare last year, but 10% of that was on diabetes, which is $300 billion. I mean, you're an old Navy man. That's like the budget we had for our Defense Department for many years before these wars. So, I mean, it's a national urgency, it seems. But if we can get a hold of it and provide better care that might be more cost effective, but certainly that has better value, I think that's where the healthcare system is going. So why don't we take a break here, and then when we come back, I want you to help us understand even better what other forms of the patient-centered medical home will look like in this era of healthcare transformation. Sound good?
Sounds good.
Okay. I'm your host, Josh Green with Healthcare in Hawaii, and today I'm with Medical Director John Baleix from HMSA.
Aloha, I'm Jay Fidel, founder of ThinkTech Hawaii. We are a digital media nonprofit that covers things that matter to tech, energy, diversification, globalism, and progress for our state, the state of Hawaii. We broadcast on community television and on Oceanic Cable Channel 16. We also stream our shows and interviews live on the internet as both radio and video, and of course we post them here on YouTube. We collaborate with the Hawaii Venture Capital Association to present monthly luncheon programs on subjects of interest to the business community. And we write for the Honolulu Star-Advertiser. ThinkTech works hard to raise public awareness in Hawaii. Check out our website, thinktechhawaii.com, and come to our YouTube channel, ThinkTech Hawaii. We hope you support our mission and that you like our work. I'm Jay Fidel. Mahalo.
Welcome back. I'm Josh Green, here for Healthcare in Hawaii. I'm your senator from the Big Island and ER physician. Today I'm joined by John Baleix, who's an HMSA medical director, really tasked with the large job of looking at healthcare transformation in the state of Hawaii. John served for 29 years in the Navy and then was assigned to Hawaii around 2000, where he began to get a good feel for our culture. But really, he's been embedded in better care for patients, and he brings that experience, really an empathetic experience, to the healthcare transformation era. He's been launching a large program with his colleagues at HMSA called the Patient-Centered Medical Home, and before our break gave us some examples about how diabetes educators and other allied health professionals help in the healthcare system. But I want John to unpack this even further for us and tell us how it's really going to make people healthier in the state of Hawaii. So John, tell us more about the Patient-Centered Medical Home. Give us an idea of what patients out there might expect, because I'm pretty confident that our doctors now understand Patient-Centered Medical Home, but many patients might not even know that their physician or their nurse practitioner has engaged in this. How do they know? How is it going to help them?
So, I'll cite another great example from the physician community that we're working with here in Hawaii. And so we talked about one of the roles of primary care is to anticipate those trip points that we're likely to encounter as we go through our life. So typified by a 50-something-year-old gentleman who early this summer got a call from the medical assistants at work with one of our internists here in Hawaii. And they said, Mr. So-and-so, you're due for your screening for colon cancer. I'm not interested in that. And they said, well, would you at least take care of these cards we're going to send you in the mail so we can make sure you don't have any issues? All right, I'll do that. So he gets the cards in the mail and mails them back in. All three of them are positive for blood. A sign that there's something going on in the intestine, could be cancer. So the MAs again then call him and say, Mr. So-and-so, you were positive on your screening
These
test.
are medical assistants,
Medical
not the
assistants,
docs, right?
I'm sorry, yes, medical assistants. So a part of the team,
Right.
patient-centered team, not the doc. Calling the patient, not waiting for the patient to call in them.
Sure.
So get scheduled for colonoscopy, look inside, and they find it early cancer. The gentleman gets scheduled for surgery, has the operation, they find an early colon cancer. It has not spread, all of the lymph nodes are negative, and the internist sees him for the first time in 10 years post-operatively. He's had the
Wow.
surgery. Those medical assistants save that guy's life.
Right.
That makes a huge impact for that gentleman,
Right.
for his family, his loved ones, his friends, and for the company who he works for.
Right, and it benefits so many people because he gets to keep working, he gets to keep providing for his family, and by the way, by just doing a simple screening, which these medical assistants as part of the Patient-Centered Medical Home recommended, probably through team conversations, team huddles, whatever, with their doc or their nurse practitioner, they were able to, by catching it early, he didn't have hundreds of thousands of dollars of advanced health care, which might not have even helped him.
That's probably true. I didn't even think of that. Yes, I should as an insurance company, but yes, it was much more affordable. But it began because that clinic had a data base that they could see all their patients and track multiple health status points for each of their patients and see when each of them were due for this or that, and the staff were trained to act on it. So the doc could focus on the sick patients that were in front of him, and his staff could help keep the others as healthy as possible.
And we've spoken about that on the show a few times before, but maybe it's a good time to bring it up again. You're talking about electronic medical records systems?
Well, this was really a registry, if you will. It's a registry of all the patients under a doctor's care. About, I guess, 60% of physicians in Hawaii are now using electronic medical records, and they're great machines for taking data in. They are not so good at putting it out in useful ways.
Right.
And so HMSA several years ago began working with a company out of Hilo called Applied Research Works to develop a registry for primary care physicians to show them this valuable information for their docs so that they and their staff could take better care of the whole patient.
And so that doctor is able to look at any number of patients and how many of their patients might need screening for colon cancer in this case, or might need their follow-up checkups for diabetes.
Exactly.
Okay, and then they translate
or
that.
kids who need immunizations.
And then they use that in the context of the team to do outreach and get those patients in at the right time.
Yes.
And what's is this COSIVA?
That's COSIVA is the name of the web tool.
And so tell us how, this benefits patients because then they are getting better quality care. Are we seeing results that we have over cross?
Like with this one doctor, his team really took flight over this last summer, and so I asked him. That's how I learned about this. I said, "Are you finding things?" And he said, "Yeah, we found 2 colon cancers just this summer."
Right.
And had another physician internist from IAEA who leads a group of docs, and he said, "John, can you give us the data en masse on the population level of these early discoveries?
Right.
That would be marvelous and powerful, and it may be the one benefit of ICD-10.
Yes.
The current coding system doesn't give us the stages of cancers, for instance.
Mm-hmm.
If it's metastatic and spread all over, yes, then you can code for metastasis.
Yes.
But just for the stage of a cancer so that we could report back to the teams, hey, look at the cancers you're finding are really early, and that's a result of your having this team proactive approach.
It sounds like the beginning of the data age for real in healthcare. And we a couple weeks ago, we had Christine Seguda here with us, who was the executive director of the Hawaii Health Information Exchange, and she spoke about a future that she envisions where doctors have registries and EMR systems, electronic medical record systems, where they can look at their patient population. That data can go into a centralized portal that's safe, that doesn't share anyone's private information, but only with the other doctors, and then it brings back information after they've had adequate tests. Is that what HMSA is participating in?
That's what HMSA is a big sponsor of the Hawaii Health Information Exchange, and the COSIVA platform was built to get us there faster and then to augment the capability of that. The key, though, as we build these systems, is to integrate them into the clinical workflows so that we don't add extra workarounds, additional administrative burdens, or anything that really takes the care team off the ball of taking care of the patients.
Let me ask you about that, because I've heard some people tell me stories. Hey, Dr. Green, I have this other doctor who just looked at a computer screen during my visit, or did I just become a number in their practice? How do we prevent our system from becoming so automated that patients don't feel left out? How do we keep that human element of the patient-physician relationship intact so that we can deal with the depression and deal with the meaningful concerns that patients bring to us as doctors without becoming so reliant on these very powerful technologies that might lack, say, the human touch?
That's where the art of medicine comes in, I think, and some thoughtful planning into the workflow.
Yes.
One way that we've talked about a bit with the team to address the whole patient is with questionnaires. The support staff can help address some of the more of the concerns of the patient that might not come up with the subject of the visit. So that's one way to augment that, to make sure we address the real needs of the patient. The other thing with the computer age, what a number of docs have found, and imagine this is the computer, is to turn it so that both the patient and the doc can see it, and then we fill it in together. That can be reassuring for the patient that they see that the doc is actually following a framework that keeps them on track. The one thing that you need to remember is to make eye contact so that we're not just working with a machine and we forget the human aspect. But so there are pros and cons, and the really high functional healthcare systems that are integrated, they have artificial intelligence working in the background, and it puts just-in-time prompts so that when the patient is checking in with the receptionist, for instance, the receptionist gets a reminder pop up that Mrs. Jones is due for her mammography, and that the receptionist is empowered to talk with Mrs. Jones about that right then and there, can put in the order, get it scheduled, all before the patient's even seen the doctor.
Right, and it sounds to me like if we get the system working right, we'll cut out some of the things that the doctor might not normally be, tasked with processing, and instead can spend more time perhaps on a good thorough examination or a really meaningful conversation in that limited time that we have with our patients, rather than worrying about checking off, did you get this test or that follow-up. So again, part of the team, those are very essential parts of healthcare. Making sure that someone had their mammogram, someone had their colonoscopies, the children had their immunizations, but that more of the meaningful, time spent with your provider, whether it's a doc or a nurse practitioner or a physician assistant, is actually right on kind of the bread and butter, tougher stuff to deal with that you really need face-to-face.
It's no substitute.
Yeah, and I think that that's going to be very important for people. I think in this kind of modern age, every one of us gets frustrated if we just get that automated voice on the other end of the phone line, and I don't think that we want our healthcare providers to become that, but we're mindful that the world is changing. What else are you seeing with patient-centered medical home? What other examples do you see? Patients, are they engaged? Are they benefiting from it palpably, or are we still early in this process?
No, I think there are significant improvements in the care that patients are getting as a result of Registry and organizing the team in the office to work in a concerted, coherent, organized approach to the patient care. You work in emergency department. You don't have any control over who's coming in, and it can seem sort of chaotic sometimes.
Right.
So organizing, thinking ahead, and planning for the patient's visit so that everybody is at the top of their game and can help take care of the whole person when they leave, so that you don't have a patient come in and leave and you say, oh, I wish I had talked to them about this or that. With this organized approach, we want to prevent that.
Would you say, this is just a question I've never had an opportunity to ask you before, John, would you say that medicine became so complicated and so complex in this this generation, with so many more tests and diagnoses, all these diagnostics that are available, MRIs, CAT scans, subspecialties, that this was a absolute necessary reality, that we were going to somehow, over time, have to go to a patient-centered medical home system because it was just simply, there were simply too many moving parts for your bread and butter family practitioner to deal with everything without a team. Is that what we're talking about?
I guess maybe, think analogy of flying an airplane or something. Will Orville and Wilbur Wright airplane was pretty simple. I guess there was just a joystick or whatever you call that thing that drives the plane. But now all those gauges and buttons and switches and whatnot, but it's all pulled together in a dashboard, and that's kind of what the future of healthcare maybe needs to get, like you're describing, is something that pulls all the information just in time for the physician or the caregiver with the patient, so that things aren't missed, things don't fall through the cracks, and we can help see ahead where the patient might trip up and address that before it becomes something of concern. Yeah, maybe it is just a constellation of events and accumulation of technology.
It's hard to know, but it's really interesting to hear your perspective. We're going to go to break again. I'm Josh Green, Healthcare in Hawaii, here with John Baleix, HMSA Medical Director, talking to us about healthcare transformation in our state.
Aloha, I'm Nicole Horry for ThinkTech. For nearly half a century, the Hawaii Foreign Trade Zone No. 9 has brought the benefits of the Foreign Trade Zone program to Hawaii businesses and entrepreneurs. DBET, the Department of Business, Economic Development, and Tourism, operates Hawaii's Foreign Trade Zone program to encourage international business and economic development. The Foreign Trade Zone's mission is to increase the amount of international trading activity in Hawaii, thereby providing employment opportunities for the residents of our island state. For more information, see ftz9.org. I'm Nicole Horry. Mahalo.
Aloha, this is Josh Green, your host at Healthcare in Hawaii. I'm working in the Senate and in the Emergency Department, but today I have a special expert, John Baleix, who is a HMSA Medical Director focusing on healthcare transformation in our state. For our last 30 minutes, we've been talking about a new integrated model called Patient-Centered Medical Home, and how through many technologies we're able to deliver better care, get better quality, in some cases prevent serious illness by getting screening at the right time for our patients. He gave us a case of finding an early colon cancer in a patient because of a good system with medical assistants helping a doctor. now I'd like to turn to kind of a further exploration of this healthcare system as it's changing. John, you talked to us about patient-centered medical home, but there's also this term that's been kind of bouncing around called medical neighborhood. Could you unpack that for us a little bit?
Sure. So we've been talking about primary care, which is what patient-centered medical home is all about. The home, for those who don't know, the term originated here in Hawaii from Dr. Cal C., a pediatrician who's made his life about taking care of kids, and particularly kids that have special challenges in health. And I guess he envisioned the home as the place where we go to nurture and grow, and thought that that's what healthcare should be too. For those kids, that's where the term came from, and we're honored and humbled to have that before us. But as you know, anybody who's had serious illness knows primary care is the foundation, but there's so much more in our complex system.
Right.
And people refer to that as the neighborhood. So that space where the primary care and the specialists and the hospitals all need to work together to safely care for people and keep them from falling through the gaps between. And so the medical neighborhood is the term that we apply to the opportunity to coordinate all of that in a more effective way.
Have we been poorly coordinating it in the past? I mean, this is obviously not new to us, that we have specialists and we have primary care providers, and we need both. What's been the challenge? What's been the problem historically? Have we had you mentioned a disjointed system earlier. Is this helping us organize and integrate the system?
Most definitely. I think the Institute of Medicine put it in perspective well with the visualization that every day in America we have the equivalent of a jumbo jet of people dying from medical errors. And their follow-up report, Crossing the Quality Chasm, spelled out a number of the challenges. We talked earlier about access, but system fragmentation. We alluded to that a bit. That was a major part of it. And then technology, although it brings great things, it complicates our life also. And so like in flying, we talked about that earlier, the aerospace industry has distilled things down to a safety checklist. Before, pilots who may have been flying for 20, 30 years, they go through a safety checklist every time before they fire up the engine and take off, because there's too much at stake to do otherwise. Well, we're learning from our colleagues in the aerospace community that we need to do the same thing. Mark Chasen, the president of the Joint Commission, talks about being inspired by the high reliability organizations like commercial aircraft, aircraft carriers in the Navy, for instance, nuclear power that has operated with a very dangerous business, but done so safely. And it's all about reliability. Look at the auto industry and think about the makes of car that we have come to just inherently trust because their reliability is so high. They've been doing that for decades because they've always been working on reducing variation to ensure that you get the same thing every time and that it works as designed.
Let me bring you back to the medical neighborhood. So you're saying we take some of these good tales, these experiences we've had with aircraft carriers and high-risk professions, and we're now applying that to the healthcare field.
Yes.
How does that work out with the medical neighborhood?
So what it works out is we need to partner with everybody who's involved, and we need to measure things. Dr. Chasen gives the example with hand washing, for instance, I think it was 8 hospitals in metropolitan Houston community. And you think everybody in the hospital is washing their hands when they're supposed to. But when you measure things, sometimes you find out it's not exactly as you expect. When they measured hand washing, they found that only 48% of the time people were washing their hands. They said, well, how come? Are they just lazy? What's the deal? So they studied it. Well, to study it effectively, you have to have, as Dr. Chasen says, a culture of safety. And what does that mean, safety and quality? It means you have to have the leadership say that quality and safety is paramount. And we feel so strongly about that we are going to celebrate when people point out problems. Not look for blame, look for why, and thank people for bringing concerns to light. And then committing to studying and uncovering the root causes of that and addressing it. Sounds like a lot of work. It is a lot of work. Edward Deming said in the field of quality improvement, there's no such thing as instant pudding. You got to roll up your sleeves and figure things out. So in the community, in the neighborhood, rather in the medical neighborhood, we have to find opportunities to study things, to find out what it will take to make those systems work better. Data, again, is really important. Data highlights where we might want to start because we're having lots of problems there. Data can highlight, if we have the measurements in place, where we're doing better, where we're not doing better, and so that we can adjust and continually get better and better. We talked earlier in this hour about the importance of data, and it really is fundamental to take care of the whole patient, fundamental to see where there are opportunities to do things better, particularly in terms of quality, cost as well, and then data so that we can see the impact of interventions we make to improve things.
So if I'm a patient and a doctor, in the community, it all sounds very relevant to make sure we have data that we're actually delivering a good service for our patients and for the people that are paying for the care and the businesses. But what does it really mean to the doc? Is that just another thing for the doc to work on, or is that hard work, does that translate into more opportunity for them, not just to work together with their colleagues, but does it translate into new opportunities for that primary care doctor to, in this medical neighborhood, get their patient more quickly to a specialist or more efficiently to an outcome that's safe, or does it ultimately yield them more time together? What does it do?
So more and more in healthcare, thankfully, we are studying the conditions that are best treated with this or that care. And getting the right person for the right care as quickly as possible is a big piece of providing quality care. And data is how we do that. And getting somebody the wrong care can put them at risk of bad things happening when they're getting something that they don't really need. And so it's all about quality improvement using evidence-based and enhancing the opportunities for effective collaboration of primary care with the specialty community and the hospitals.
Are we just forming this now? Is the medical neighborhood coming into place? How is it affecting our patients once again? Let's say I was that gentleman earlier that came in for the screening, and I got those test results that showed I had to have a colonoscopy. Did that trigger a switch that said turn on the medical neighborhood for this gentleman, and let's get him quickly over to the gastroenterologist specialist and the surgeon?
I suppose that is a model or an example of the medical neighborhood, but it applies, ultimately to all specialists and all hospitals and all, other modes of care too. And we can't solve it all simultaneously. We'll probably work with those who are eager to engage and make the system better, more efficient, and I think that we should steal shamelessly from our competitors, as they say, but Kaiser got it right when they said what we need to do is make it easier to do the right things. And that's a big piece of medical neighborhood. We need to make it easier for the specialists in the primary care to communicate, make it easier for the hospital to hand off the patient back to primary care so that the patient doesn't get left in the void and end up not knowing what to do and end up getting sick when we want them to get better.
You just made me think of something as you said that. You've spoken to me often about patient-centeredness in the past, and that the patient should be at the center of this medical neighborhood. They live in that neighborhood, so to speak. How is this working for our patients? At HMSA, you cover maybe almost 800,000 individuals in the state, I think. Are patients able to be in this neighborhood? Are they able to then kind of walk in the neighborhood, see the physicians that they choose to, follow their own data? How does it work? I know how it works in Kaiser, and that's been a long-standing tradition for Kaiser. Are we moving that direction for our patients?
Absolutely. Some of our partnering organizations like Hawaii Pacific Health have a patient health portal that the patients can go on and see their lab and imaging results. And COSIVA, we talked about that earlier, it has a patient portal also, so patients can access, get in contact with their physician and their care team, as well as begin to see some of their lab results and whatnot, to be able to actively participate in their care. So that's the technology that pieces it together. But as we were talking with docs and their staff about how can we help patients better take care of their illnesses like diabetes, how can we more effectively talk with patients who say, yeah, I know I should get my screening test, but I just don't want to do it. How do we have more effective conversations? And I think the leaders in this really come from the field of addiction medicine.
Interesting.
William Miller and Stephen Rolnick took Carl Rogers' client-centered approach to psychotherapy and applied it with one of the most challenging patients, if you will, patients that suffer addiction, and learned that you really get nowhere if you don't start with where the patient is at. And so we want to learn from that and afford opportunities for all of us to learn how to do that better. It's kind of like for people who have had teenagers. You learn fairly quickly that if you tell them what to do, it doesn't always go so well. We need to seek first to understand before we then impose our understanding on them.
Let me ask you, John, have you noticed, do we have any cultural challenges in Hawaii that others might not have with that patient-centeredness model? In my experience, some of the Asian culture here are very accepting of the physician guidance in the exchange, whereas I found when I was practicing on the mainland that there was a little bit more pushback. Is that going to be a challenge for us? Do we just have to come along based on our own cultural tenets? What are you thinking? What are you seeing?
I think one of the things that makes living in Hawaii such a rich experience is the diverse cultural background of the people that are our neighbors here, and patient-centeredness and effective communication is all about relating to the person that's in front of you. And the example I experienced when I came here after living in Italy for 4 years, and I'm talking to my diabetics, you can't be eating bread and pasta, and they're like,
yeah.
Just a sort of superficial example, but
yes.
You got to make it real and meaningful for the person you're talking with, so they can act upon it.
And that was really a central message that we had from Professor last week when he was speaking about how in the Native Hawaiian community there's been a fairly large disconnect between patients getting and seeking on their own behalf an advocacy position for their own health, that they suffer a lot more complications from diabetes and hypertension and heart disease, and not only is there a shortage of access, but there's a shortage of empowerment in some ways in certain communities across our state, and the Hawaiians have suffered greatly. The average lifespan is significantly less than we're seeing in Caucasians and the Japanese population here. And I think that achieving that patient-centeredness in the medical neighborhood and in this transformative process is going to require that we do it in a culturally sensitive way, that we have Native Hawaiian practitioners. Is HMSA and really your team, are you taking into consideration some of the cultural differences? Have you already begun to work with other organizations, not just like the physician organizations that I've been a part of, but Native Hawaiian health leaders? How's that going?
Yes, we have members of our executive leadership team that are leading the effort to help improve the health of Native Hawaiians. Elisa Yadao and Tim Johns, for instance, interact on a regular basis with community leaders to help advance that. In the clinical domain where you and I work, we need to do that considerably more. Partnering with the Hawaii Primary Care Association, that it's an advocacy group that partners with our federally qualified health centers around the state, is another more operational way that we can begin to first understand the needs of the community and then learn where we can help make things better.
Well, I'm really glad to hear that. So I think we're going to go into our last break, but when we come back with healthcare in Hawaii, we're going to ask Dr. Baleix his vision of healthcare for the future and what he'd like to see in the next 5 and 10 years. Again, thank you for joining us here on our program.
I'm Bill Spencer, president of the Hawaii Venture Capital Association. We do monthly luncheon programs with ThinkTech about things that matter to Hawaii entrepreneurs, investors, and business service providers. So join us on the fourth Thursday of every month at the Plaza Club. For information about upcoming events or to join our mailing list, visit hvca.org. See you there.
Aloha, welcome back to Healthcare in Hawaii. I'm your host, Josh Green, Senator from the Big Island and emergency room physician. Today I have had the distinct pleasure of having a senior medical director from HMSA who talks about healthcare transformation in our state, John Baleix. He's a physician. He worked with the Navy for many years in systems and brings much of that wisdom to our patient care here in our state. John, in the first 45 minutes of our program, has talked about patient-centered medical home, the medical neighborhood, patient-centeredness, new models of care to get people really meaningful care that's both cost-effective and actually helping us to diagnose illness early. But now I'd like to turn it over to John and say, John, what will the challenges be, do you think, in the next 5, 10, 15 years that we'll face? What's your vision for healthcare? What will make it better for our patients here in our state?
The challenges are many, and with that comes many opportunities. Our goal at HMSA is to provide access to quality, safe care that's sustainable for our government and industries that fund it. We're learning, it's a bit humbling for a big insurance company to learn, but the reality is we need to partner with the provider community and with our members and patients and our employers, all the stakeholders really, to learn how to make the system better. We all have grown up with and inherited a episodic fee-for-service finance operation, if you will, that has been good in fostering innovation, but the unfortunate consequence at the same time is that it's led to fragmentation. So we need to partner in the sense of listening to one another, respecting one another, and forge the future together. And we need to partner in the sense of enhancing those touch points, make it easier for people to communicate so that we have less frustration in our work. We are able, therefore, to be more joyful. Maybe that will help address some of the doctor shortage at the same time and make our family life better too, as well. But really help us take better care of the people who are our charge and our responsibility.
So you foresee a system where we're looking at just focus on quality rather than these episodic, I'm going to see you every 2 months or 3 months and bill for that, so that the healthcare system is more, I guess, a partnership, not just between HMSA and the physicians, but between the physicians and the patients. Is that the kind of partnership you're envisioning?
Yes. And so the payment model will probably evolve as we shift to that. And we need to do it together and transparently because there are lots of lives impacted with this. And so we want to do this in a transparent, fair, but deliberate way that benefits the community.
It's so interesting to hear you say that, and just before we wrap up, it almost sounds like HMSA and your colleagues are in some ways transitioning from being an insurance focused entity to almost a public health entity in some ways. Is that a fair assessment?
We just celebrated our 75th anniversary, and that's a time to celebrate our roots, and our roots are as a community service organization. And
yeah. Well, it's really...
Sorry, that's what it's about.
Yeah, it's really impressive to hear that from a medical director. And I can say, for one, I've seen really quite a change in the culture at HMSA in these last few years. And nothing is perfect in our healthcare system, God knows, we all know that. But it's refreshing to see this patient-centered focus. It's refreshing to see a sense of service that can hopefully be embraced by both the physicians, the insurers, and the patients. So why don't we end there? And I just want to thank you for coming on, John.
My pleasure.
It's been a really great pleasure for me as well. And I wanted to say welcome back, everyone, to Healthcare in Hawaii. We're going to keep doing this show and get to the root of all challenges in our healthcare system. Again, I'm Josh Green, your host with Healthcare in Hawaii, both from my capacity as a senator and emergency room doc, but mostly a guy that wants to see you get better care. Take care.